Hello, everyone. Thank you for standing by, and welcome to our webinar, Updates in Contraception, Birth Control After Baby, sponsored by IsisParenting and presented by Dr. Lillian Schapiro. My name is Nancy Holtzman. I'm the Vice President of Clinical Content and Online Learning here at IsisParenting, and I'm a mother-baby nurse specialist and a board-certified lactation consultant. During tonight's presentation, all participants will be in a listen-only mode. However, you may submit questions to us at any time by typing them through the chat feature located to the left of your screen. We've incorporated many of the already submitted questions into the presentation and will take additional questions at the end as time permits. Tonight's webinar is being recorded, and you will receive a link to the recording by email tomorrow along with additional resources. So if you missed something or need to step away from the computer for any reason, that's okay. IsisParenting is proud to host tonight's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We provide innovative programs and a highly selected assortment of products for expecting and new families in our 4 Boston area centers, our 5 brand new centers in the Dallas area, and 4 new centers in Atlanta, Georgia, where Dr. Schapiro practices. Visit our website at IsisParenting.com to learn more. As I mentioned, I'm Nancy Holtzman, and I'll be your moderator tonight. With me this evening from IsisParenting is my colleague, Chris Just. Chris is a certified nurse midwife with over 20 years of maternity care experience in educational and clinical roles. Chris oversees the clinical component of IsisParenting's prenatal education programs and is actively involved in hospital partnerships and community outreach. She serves on the board of the Massachusetts Healthy Mothers and Healthy Babies and is a member of the Massachusetts Special Legislation Commission on Postpartum Depression. And she is a member of the Mass Perinatal Quality Collaborative. Her focus is on increasing access to relevant evidence-based information through on-site and online education, scholarships, community classes, and social media. Chris received her master's degree in nursing from Yale University and a bachelor's from Millbury College. Welcome, Chris.
Thank you, Nancy.
And with us tonight is Dr. Lillian Schapiro, an OBGYN practicing in Atlanta, Georgia. She graduated from Yale College and Albert Einstein College of Medicine with distinction in obstetrics and gynecology. As a medical student, she did an elective in rural maternity care in Kenya and then completed her residency at Chapel Hill in North Carolina. Recently, she's returned to Africa to work on a gynecological unit in the Congo and is planning a trip in October to help address postpartum bleeding problems in Nepal. Dr. Schapiro is in private practice at the Peachtree Women's Specialist in Atlanta, Georgia, where she's been a partner for over 10 years. She is the mother of 16-year-old twins and a 10-year-old child. She's navigated the transition back to work and breastfed her children successfully, and Dr. Schapiro enjoys the opportunity to coach women through their pregnancies and deliveries, providing education and support. Wow, that's quite an introduction. Thank you, Dr. Schapiro, for joining us this evening.
Thank you. Well, hello, everybody. I'm delighted to be here tonight. And as she said, I'm an OBGYN in Atlanta, Georgia, and I'm delighted to have people with so many different perspectives. We've already gotten some super questions, which we'll be getting to. I'd like to first start talking about culture and how that influences the postpartum period. So cultures from across the globe often have ritualized periods of sexual abstinence after childbirth. Unfortunately, in some of those cultures that actually give women 6 months of abstinence after childbirth, the men have more than one wife. And I think that it's sort of a part of the price we pay for monogamy in this country, that women feel pressure to resume sexual intercourse very shortly after delivery. And doctors, we give them 6 weeks for a vaginal delivery, 8 weeks for a C-section. Obviously, all women are not the same, but most women end up getting the same recommendations. Some people have obviously better relationships with their spouses, and some spouses are more understanding than others. Based on my years of experience, I think that most women need the full 6 months, but also based on my years of experience, I think very few women get the full 6 months. So sex after the delivery, whether it's a vaginal delivery or a C-section, women have pain. obviously the penis is banging into either hitting the episiotomy or the tender perineum or the uterus, which has been incised for the C-section. The hormones released while you're breastfeeding suppresses your estrogen. Many women have vaginal dryness while they're nursing. I don't think that's well recognized or well addressed, and I always encourage women to use lubrication. And actually they can use, for some women, even though they can't take oral estrogen, they can be very successful if they're having extreme dryness using some vaginal estrogen. So the whole time they're nursing, if it is a problem, it may continue to be a problem. So breastfeeding is not contraception. Now, women who exclusively breastfeed are less likely to ovulate than those who are not breastfeeding or who are breastfeeding only part of the time. By 6 months, when solid foods are introduced, women who even are exclusively breastfeeding, the baby isn't needing them quite so much, and they are more likely to start ovulating. I delivered someone the other day who had a 10-month-old at home. So clearly she had not followed my instructions, and her husband was in the room when I told her that they should not be having sex for 6 weeks. And she was exclusively breastfeeding, and she clearly ovulated quite early because she had to have gotten pregnant at 4 weeks. And the other issue is that you don't know when you've ovulated until your period starts 2 weeks later. So it's very difficult to use a rhythm method when you're out of your rhythm. Certainly some women are very, very sensitive to their cervical mucus, but I would not recommend that a breastfeeding mother check her basal body temperature, because your temperature fluctuates so much with nursing that I just don't think that that would be a good method. For women who are exclusively breastfeeding and choose to use that as their primary method of contraception, they just need to be comfortable with the fact that they may end up with the pregnancy, that it is not 100% effective as contraception. An excellent method of contraception for breastfeeding mothers are condoms. Condoms do not interfere with breastfeeding. They are extremely effective when they are used. The one official number is 86 to 98%. Condoms are not effective when they remain in the drawer. And it's depending on the relationship that your patient has with their partner, they may or may not be comfortable discussing condoms. It's often come up by the time someone has a child, and many women know that their husbands or their partners will not use condoms. But for those that do, it's certainly an excellent option. A lubricated condom can also help with lubrication issues. Diaphragms are 80 to 94% effective when used with spermicide. For a woman who's never used a diaphragm, it can be a little complicated in the midst of breastfeeding and dealing with so many new things of a new baby to start learning to use a diaphragm and sort of have one more thing. But certainly for a committed person, it's an excellent method of contraception. It has no hormones. For women who have been long-term diaphragm users, they need to be advised that they need to be refitted at about 6 weeks postpartum. The body changes with pregnancy, no surprise to any of us, and you do need to have a diaphragm refitting after the delivery. And that has to be done by a health professional. They can't just gas, and diaphragms obviously require a prescription, so they will have contact with someone who can fit them in order to be fitted. So IUDs come in 2 flavors now. There are with hormones and without hormones. I had one great question about the two IUDs that have progesterone in them. So progesterone does not interfere with breastfeeding. The two IUDs with progesterone are called Mirena, which has been around for a long time, and Skyla. So Skyla is new, just recently FDA approved, and it is approved for a nulliparous person, someone who has never been pregnant, because it is smaller than the Mirena. So someone who is breastfeeding has presumably had a baby, and so the Skyla is not really something that they need to think about. The Skyla is more for prevention of the first pregnancy. So IUDs are 99% effective. The patient really doesn't have to think about anything other than making their appointment, coming to the doctor, and having the IUD placed. So the IUD without hormones is called the Paragard. It lasts for 10 years. It has no hormones, so it does not interfere with lactation. It also can be removed, and the patient can resume her fertility almost immediately. So as soon as the IUD comes out, if they want to get pregnant right away again, they can. The Mirena has progesterone in it, which thins the uterine lining. So we recommend that people with the Mirena use generally condoms or some other method of contraception for 2 months before they get pregnant again, because it has thinned the uterine lining. Most physicians will put an IUD in at 6 to 8 weeks after delivery. With the Affordable Care Act, most IUDs are covered. They're free. Some insurance companies do try and apply it to the deductible, but in general, they're not supposed to be doing that anymore, and most women have met their deductible for this year. It gets a little more complicated if they've delivered in December, and then we're talking about January. My understanding is, though, that by next January, all insurance companies will be required to cover the IUDs. As I said before, I think one of the most important and best things about the IUD is that they don't have to think about it. IUDs do say on their pack to check the string. I always tell patients I will check the string. They don't need to be pulling on their string.
Dr. Schapiro, this
yes.
is Chris. I just have a couple of questions. I was curious about if you could mention the failure rate of the IUD compared to some of these other methods that you talked about and we'll talk about. I'm just curious how it compares, and also what kind of side effects could a woman perhaps experience with an IUD, and what kinds of things, like, does IUD help control heavy bleeding for some folks?
Right. Excellent. Thank you. So the IUDs of the ones we've discussed so far are the most effective because they require the least from the patient other than coming to the doctor. In the heat of the moment, your IUD is already in there. You don't have to stop and get your diaphragm and put spermicide on it. You don't have to fumble around for condoms, try and open the package, or just not have anything handy, or you've run out. So I think that is a big reason why the IUD is so effective, is it requires, once it's there, it does not require further action. So the IUD with no hormones can cause heavier bleeding in women having their regular periods. It is not for women who are breastfeeding, it's a great time to put it in because they often are not bleeding. And if they are going to be breastfeeding for quite some time, that's great. And then as their periods return, it may be that it's a problem or it may not be a problem. So the IUD with no hormones, the Paragard, really, other than the heavier periods, that is its only sort of potential side effect. Some women do also have worse cramping, so it affects the actual period. The Mirena has progesterone in it, it lasts for 5 years, and it is actually also frequently used for women with very heavy bleeding or heavy periods. The progesterone acts locally inside the uterus. I certainly have had patients who have had systemic effects from the progesterone in the Mirena, but I would say the majority of people don't have any problems with it. They are, some women do have things, they have headaches. Some women are very sensitive to the progesterone with depression, and other people have a lot of spotting. Again, for women who are nursing and not producing much estrogen, they tend to not spot because they're not bleeding, but certainly annoying spotting can be a side effect.
And what about the insertion? I know you said the Skyla is smaller, so I know the Skyla lasts 3 years, correct? And the Mirena is 5?
Correct.
And the Skyla is smaller, so as far as insertion goes and discomfort, could you speak to that a little bit? I know that's a question that people often have about the IUD.
Absolutely. So they both go in with a very small tube. So even someone who's had a C-section, in general, the cervix has softened and opened a little bit. So getting an IUD in postpartum is almost never a problem. Where the Skyla is bigger is after it is open. So all of the IUDs go in tucked into a tube, and then when they get pushed out, the arms of the T, the top of the T opens. So the Skyla's arms don't open as far, and it doesn't come down as far, so all parts of the T, the three limbs there are all shorter. But it's not, the Mirena is not significantly larger in the actual tube that gets put into the cervix to introduce it into the vagina, into the uterus. Mm-hmm. And the IUD can be placed, so postpartum, the IUD is generally put in at 6 to 8 weeks so that the uterus has time to contract back to its normal size, and also so that it's not so soft, which can be a problem with perforation or putting it in all the way through the uterus. That's pretty rare, but more common in a postpartum uterus, which is still boggy. If someone's nursing, we don't wait till their period, but in general, we like to put them in when we're very certain that someone is not pregnant, which is often right after a period. Mm-hmm.
Yeah, someone actually asked a question if the IUD needs to be inserted while one is on their cycle.
So not postpartum.
Right, not postpartum. And the other question was, someone said, did I hear correctly that a side effect of Mirena could be depression?
So
now, I
very
understand
rarely.
That initially a higher dose is being released over the first couple weeks, is that right? And then it tapers off?
Correct.
Mirena? Right.
Right. So of the progesterone-related contraceptions, it is certainly the lowest amount of progesterone in your system. But it is definitely something, especially in the postpartum period, to be aware of. And if I had someone with a history of depression, I would probably lead them to something else, or someone who was really suffering with a postpartum depression.
Thank you.
So while we're on the topic of progesterone, birth control pills, very popular. Most birth control pills have a combination of estrogen and progesterone. The estrogen supports the uterine lining, and the progesterone thins the lining. It is the progesterone that makes a woman not ovulate. So the progesterone is, in a sense, the only crucial part of the birth control pill. So let's go back for 1 second to the IUD with its progesterone. So the IUD, the Mirena, the progesterone IUD, works in various ways. So it changes the cervical mucus so sperm don't swim in. It changes the uterine lining to keep it thin so you don't have any, sperm really can't swim up in there. Some women continue to ovulate on the Mirena and some do not. So it is not working by preventing ovulation. Birth control pills work by preventing ovulation. Estrogen suppresses breast milk. So the hormones that have you make milk on their own suppress your own normal progesterone, like we talked about earlier. So your own breastfeeding makes your estrogen go down. And so putting estrogen back in the system will interfere with most women's breast milk supply. So the birth control pills, the progesterone-only pills tend to be called the mini pill, which is unfortunate because if it's not mini, it has the full dose of what you need to not get pregnant. So this mini pill or progesterone-only pill is a terrific option for breastfeeding mothers. Some women know that they're going to be able to, that they will not be able to take a pill every day. Others have successfully taken pills in the past, and they feel very comfortable with it, and they're very good at it, and they go back to it. So emergency contraception, Plan B, is a whopping dose of progesterone, and that is safe to take while you're nursing. I certainly don't recommend frequent use of Plan B. If you're needing emergency contraception on a regular basis, you should encourage people to be on the progesterone, the smaller dose for regularly every day, or to seek out something that is going to allow them to not have emergencies. Okay, so the patch is the highest dose of circulating estrogen of any of the contraceptive methods that we've talked about, or actually that are out there. So while you're nursing, you absolutely cannot use the patch because the estrogen will suppress your milk supply.
And Dr. Schapiro, could you talk just a little bit for when folks are done breastfeeding, if they're interested in the patch, what are some of the side effects associated with this method? I don't know how much folks know about the patch, so just curious to hear a little bit more about that.
So the side effects of the patch are pretty much the same as a birth control pill because it's an estrogen-progesterone combination. You put on the patch for 3 weeks, and then you take it off and have a period. The company that makes the patch will text you. I don't know if you want it up on your Facebook, but they have all kinds of different ways to contact people to remind them because it's actually, I think, easier to remember to do something every day or never as opposed to on a 3-week and then a 1-week schedule. Like that Sunday can come and go very quickly. There's a little bit higher rate of blood clots of women using the patch because it's a higher circulating rate of estrogen. But I haven't, so in people who are sensitive to estrogen, who get migraines with estrogen, this is not a good method for them. But for the most part, people who use it like them. So Depo-Provera shots, we got a lot of questions about Depo-Provera. So theoretically, Depo-Provera being only progesterone should not interfere with nursing. I think I, as well as many of our listeners, know that that is not the case for many people. It's an excellent method for people who don't want to think about anything on a daily basis. So I understand a lot of physicians are giving Depo-Provera in the hospital immediately. If you have a patient or a provider has a patient, certainly teenagers, you don't want them to leave without contraception unless they have a planned pregnancy, which is often not the case. So for someone who wants contraception but does not seem to be able to follow through with their plan, the Depo-Provera is a great option. Certainly Depo-Provera can cause acne, weight gain, bloating, depression. It needs to be used carefully. And certainly in the postpartum period, you're prone to any of those things. So I think it's a good method for people who need something that is taken care of by others. So Lunelle is fairly new. It's a monthly hormone injection. It is estrogen and progesterone, so big no-no while you're nursing. It has a more physiologic combination of medications because it's estrogen and progesterone as opposed to just the Depo-Provera, but it does also require the patient to return to your office on a monthly basis, which is, I would think, incredibly inconvenient. Oh, Implanon so someone just mentioned, let me go back and talk about the Depo-Provera for a minute. So Depo-Provera is supposed to last for 3 months and needs to be, thank you, and needs to be re-injected every 3 months. It can actually take up to 18 months to get out of somebody's system for them to be able to get pregnant again. So it's not something where you can simply say, oh, I want to get pregnant tomorrow, can we reverse my Depo-Provera shot? The answer is no, you can't. You've just injected this into your system through your muscle, and that's where it stays.
Dr. Schapiro, someone's asking, where's the correct place to give the shot?
So
what part of the body, I'm assuming which part of the body, which muscle?
Right, arm or buttocks. So it needs to be a place that's intramuscular, so it needs to be a place where you can really pull up and not end up going too deep. So the next method I wanted to talk about, Implanon, now called, so many people still have an Implanon in. The new hormone or the new contraceptive method is called Nexplanon. It is a single rod, and it releases progesterone that lasts 3 years. Like the IUD, you put it in and don't have to think about it, so it is 99% effective. It is safe in breastfeeding. It can also, if it turns out that you have a bad reaction, it can be removed. I have to say they have done a very good job at making sure that physicians who are putting them in are well trained, and so that it stays superficial. The Norplant was 5 rods that were quite similar to the Implanon rods, and it was really, really difficult for the doctor and painful for the patient to get all 5 of those out. So you still end up with a fair amount of bruising when you actually take out the Nexplanon, but it heals. It doesn't seem to leave the same kind of scarring, and it is put in the upper inner arm. The doctor injects lidocaine, numbs the area first, makes a little incision, and then injects the rod. And yes, it's about the size of a small matchstick.
Dr. Schapiro, I remember the days of the Norplant. I put in a bunch of those. And yeah, we've come a long way going from 5 to 1. That's definitely moving in the right direction.
Yes,
I see a couple of, I see a question here, just going back to Depo-Provera.
Yes.
Someone's asking, well, a couple of things. One person said that she was told the arm is not as effective as the buttocks for injection. And another person says the Depo insert instruction says to wait 6 weeks to start for a breastfeeding woman. Please comment. Could you
So
speak
I think
to
that
those?
gets, yes. So most people, I believe, do give the Depo-Provera in the buttocks, but some people give it in the arm. It's a big needle, so I'm thinking the buttocks is better, just because it's a big needle and you have a bigger muscle down there. So the Depo instructions do say to wait 6 weeks for a breastfeeding woman. I think the issue again is your primary concern that this woman leave with contraception, because she could potentially get pregnant before she comes back in 6 weeks to get her Depo-Provera shot. So if it is a patient who the doctor, midwife, practitioner feels that the patient is committed to breastfeeding and also going to be using contraception, or perhaps even following your advice and not having sex for those first 6 weeks afterwards, then certainly wait 6 weeks, and even consider, if it's someone who's that compliant, is the Depo-Provera really the best thing for them? So
good point.
It's a toss-up between whether you want what's more dangerous, a new pregnancy or interfering with the breast milk.
Okay.
So for people who are finished having children, there are permanent methods of contraception. The ring. Let me just talk about the NuvaRing for a minute. So the NuvaRing is, again, placed inside the vagina for 3 weeks, and then it comes out. It has estrogen. So even though not much is circulating, we do not recommend it in breastfeeding. And I misspoke earlier. The patch goes on weekly, not every 3 weeks. The NuvaRing is what goes on every 3 weeks. Goes in for 3 weeks and comes out. So back to our picture here. So the Essure is a permanent contraception, and it does not require any incisions. It's basically a tubal ligation. It is permanent contraception. It is done in the office. It can be done as early as 6 to 8 weeks postpartum, but can be done at any point. Usually we do it after your 6 to 8 week visit, or if you're on birth control pills, you want to do it during the menstrual, right after you finish your period, because you want the lining to be thin. So the patient comes to the office, gets pain medication. We numb up the uterus with a paracervical block, and then put a camera in through the cervix and can see the opening. It's called the ostia from the uterus, from the uterine cavity into each tube, and it's a nickel and titanium coil that goes up inside each tube. For 3 months, the patient still needs to use birth control, and then we follow up with a dye test, done a hysterosalpingogram, a dye test done with radiologic guidance to make sure that those tubes are blocked. So for people who want permanent contraception, if they're certain that they're done having children and they're having a C-section, certainly having a postpartum tubal ligation at the time of the C-section is easy enough to do. The other thing is a postpartum tubal ligation after a vaginal delivery, which is done right away in the hospital. That requires, however, an incision just under the belly button, and since the Essure requires no incisions, people have really moved away from doing the tubal ligation. And also after the tubal ligation, we literally tie off tie off the tubes and take out the piece in the middle, generally. You always tie the tubes. It is rarely reversible. It can be done easily at the time of C-section, as I said. It does not change your hormones. So your ovaries are right at the end of those little tubes there, and they are not affected by the tubal ligation. There is some data that women go through menopause a little bit earlier who've had a tubal ligation, but like 6 months or something like that. So not something that you would actually be aware of. The other problem, if you're having a tubal ligation right after your vaginal delivery, if they can take you back to the operating room right away, that's excellent. Otherwise, you can't eat until you go back and have your tubal because it's surgery. Great question here. Is the Essure reversible? No. That is also permanent. And you can't pull them out through the vagina and then be back to being fertile. So also in the permanent realm here is a vasectomy. So several 100,000 Essures have been done because men don't go have a vasectomy. So if the man wants to go step up to the plate, I always encourage that. It obviously does not interfere with nursing, except that they really need a lot of loving care the day after they come home and they're wearing their frozen peas. Now, right after a vasectomy, they are not shooting blanks. So men come home from their vasectomy still fertile. They must go back, and it's several weeks to a couple of months. They have to go back and have a semen analysis. The only babies that I have delivered from men with vasectomies were from men who did not go back and have their check, their semen analysis. Now, I will also say that I have delivered many babies from men who were planning to have a vasectomy and never went. I'm not sure if this looks bigger on your screen, but this is the effectiveness of various methods of contraception. Spermicide on the bottom here. So spermicide is not effective contraception by itself. Spermicide should be used with a condom or with a diaphragm. So moving up the list of effectiveness, we have the diaphragm, condoms, male and female condoms, withdrawal. So a lot of people wanted to talk about non-hormonal methods of contraception and non-invasive methods. So certainly withdrawal works for many people, as long as withdrawal works best in a long-term relationship where you can really trust him to withdraw, and he's going to be around to raise that baby if he doesn't. It's not a good method for a more casual relationship, shall we say. And obviously it doesn't interfere with breastfeeding. The sponge is back available, but not as effective as some of the other methods. I think it's hard to find a cervical cap. But that has the same issues as the diaphragm, that you have to stop and put it in. So this is just an effectiveness chart and not necessarily relevant for breastfeeding. And then the most effective or the permanent methods of a vasectomy, blocking off the tube somehow, IUD, and the implant. All right, so let me answer some of the questions that we've already had, I think, and then we'll open it up to new questions. Is that good? Nancy?
There's one question right here that I see. Dr. Schapiro says, does breastfeeding as a contraceptive work by how much you breastfeed in a 24-hour period, or how old the child is?
It's related to how often you're breastfeeding. And if the child is completely dependent on you, so if you're breastfeeding a 3-year-old and they're having regular meals in between, they're not really getting most of their milk, most of their nutrition from you. So that's, that's not going to be effective contraception. Usually if you're nursing every 4 to 6 hours, that's pretty effective, but it's still not 100% effective.
I'll just share that I've had 2 patients myself. I'm a nurse midwife who used lactation amenorrhea method, but they ended up ovulating early on and actually showed up at their 6-week visit pregnant.
Right. So, that's like the patient I talked about who she delivered when her baby was 10 months old, so she had to get pregnant at 4 weeks.
Yeah.
So it definitely happens.
This is Nancy, and I often will say to moms that any one of you sitting in this room could be ovulating right this moment and don't know it until 2 weeks when you get your period. And in the interim, if you become pregnant, you will never get your period, and so you won't know. So for the most part, the first menstrual cycle is anovulatory after you have a baby, but not always. And sometimes you don't get that menstrual cycle as your wake-up call. So although it is true if the baby is under 6 months, if you're exclusively breastfeeding, not using a pacifier or very minimally using a pacifier, and not going longer than 6 hours at night, and your menstrual cycle hasn't returned, then it's very possible that you're not ovulating, but it is not definite. So any one of you sitting at home with a 2 or 3 month old baby could be ovulating at this moment and may or may not become pregnant because of that. You just don't know. I always feel bad for moms who get their periods back 6 weeks after delivery because it just seems like such a ripoff when they're exclusively breastfeeding.
It's just not fair. Exactly.
It's so not fair.
I agree.
Yeah.
So not fair.
So here someone just asked how often do women become pregnant when relying on LAM? What's the percentage? Do you have an idea?
I don't.
I have to say, I think over the years, LAM, lactation amenorrhea method, or relying on exclusive and frequent breastfeeding for birth control, I don't have the research to quote this, but I think it's a little bit less effective because now more mothers are going back to work early and they're relying on a combination between pumping and breastfeeding. And even though you can maintain full milk production by a combination of pumping or breastfeeding or just pumping, I think there's not quite the same hormonal peak of prolactin levels. And it's also that 3 or 4 a.m. nursing session in the early morning that really does peak your prolactin levels. And some women can be very fortunate and go 8 or 9 or 10 months without getting their period back, even though their baby may be nursing 3 or 4 times during the day and once at night. But certainly some women will get their period back 6 weeks after delivery, even when exclusively breastfeeding every 2 or 3 hours around the clock.
Right, and I think also what is contributing to that, although again I don't have data, we are such a well-nourished society. I think when a woman's body is really taxed with breastfeeding and she's not taking prenatal vitamins, she's not eating 3 meals a day, that body is much more likely to not ovulate and is more in a preservation mode as opposed to a well-educated woman on a wonderfully healthy diet nursing her baby. Her body's just stronger, and so she will kick back in for ovulation. And for all these women who don't want who want something natural, or who want to rely on lactation amenorrhea, why can't their husbands use a condom? I mean, just have the men step up to the plate while you're nursing. Mm-hmm. You're doing all of this for your child. They owe it to you to allow you to breastfeed this baby for the amount of time that you want to breastfeed your baby and to get your body back while you're nursing. Condoms are always out there, and they don't affect your body. They don't affect the baby. And if you're putting that much energy into being an awesome mom, I think the men can use condoms.
Well, I agree with that, and you've been through pregnancy and birth, and they've seen you in that predicament, and certainly a few months of condom use doesn't seem like a tough price to pay. I mentioned too that I'll include the Love, Sex, Breastfeeding webinar in the link for tomorrow, where there was a lot of frank discussion on relationships and negotiation and postpartum sex afterwards and libido, because I think a lot of moms have concerns about that as well. We did have a couple questions. Oh, go ahead.
Oh, I tell everyone that to not expect their libido to come back for an entire year, partly because of your lactation hormones, your prolactin, and also because you have a person latched onto you. And when they're not latched onto you and your body inside of their body, you just want space. You just want some freedom and space, and you don't necessarily want someone coming inside of your body. And I think the body is also designed that women want to focus on the infant and get the infant to a certain age and size safely before their own natural instincts come back in to start procreating again. I mean, you have a natural maternal instinct to nurse and to nurture this baby, and sex can easily lead you to the next one. So I tell women that the goal of postpartum sex is for it to not hurt. We want it to not hurt, but it's probably not, if it's not as good as getting an extra, few minutes of sleep because you're sleep deprived. It's a trade-off.
There's a question here that says, is it normal to get an extremely light period at 4 months, or is this not a period? Is it just lochia? How do periods change after breastfeeding or after pregnancy?
Okay, so that is a fabulous question, and everybody is different. Some women, as you just mentioned, have regular periods starting at 6 weeks. Other people, I was fortunate to not have a period the whole year I was nursing. But I just got lucky. And you can't quite tell. A lot of times, though, the first period is actually really heavy, especially after a vaginal delivery. After a C-section, the periods and the lochia also tend to be lighter, and then they pick up, and certainly after you stop nursing, they often return to, if they were heavy before, they return, but there is often some protectiveness in there from how heavy they become while you're nursing.
Great. Anybody have any more questions?
Don't be shy.
A question. Yeah, I have one more question that came in. Maybe could you mention if a mom was concerned about issues like weight gain, sex drive, skin changes, menstrual cycle? Can you just summarize some of the information you shared in terms of a woman that might be having some perinatal mood issues? Would you advise her to seek a non-hormonal issue type of birth control?
Yes. Yes, I think that postpartum depression and mood swings is a huge issue and needs to be taken very seriously. So I would think that one of the IUDs, the non-hormonal IUD, would actually be an excellent option because you don't have to worry about getting pregnant in all the anxiety and difficulty with the pregnancy and with the postpartum period and taking care of the baby. And if condoms are acceptable in the relationship, then I think that's also an excellent option for someone who is having a postpartum depression.
Thank you. Thank you very much. Well, thank you, Dr. Schapiro and Ms. Just, for sharing this information. We do have the end of our presentation now, so I want to remind people to check their email tomorrow. We'll send a link to the recording as well as some additional resources. And thank you again very much for your time and for joining us this evening. We will see you at another ISIS Online event soon. Good night.
Thank you.